got Dr. Michael Mancino this morning, and we are so grateful. We know him from a lot of the work that he does at UAMS with the ECHO program and with our opioid project. So we are just so grateful that he is here. We're going to tell you a little bit about Dr. Mancino. He graduated medical school from Northeastern Ohio's University's College of Medicine. He trained for several years in neurological surgery and eventually completed his training at UAMS in psychiatry in 2004. He is board certified by the American Board of Psychiatry and Neurology as the American Board of Preventive Medicine with a specialization in addiction medicine. He's a professor at the UAMS Psychiatric Research Institute and currently the program director for the Center for Addiction Services and Treatment. He was previously the medical director of Recovery Centers of Arkansas. He focuses his clinical practice on medications for opioid use disorder, or MOUD. Dr. Mancino also has an interest in conducting clinical trials for medications development for patients with psychostimulant and opioid addictions, and is funded by the Clinical Trials Network on a project designed to improve retention in MOUD treatment for patients with opioid use disorders, as co-I with Dr. Alison Oliveto. Dr. Mancino is passionate about increasing access to MOUD across the state of Arkansas. He works in conjunction with the Arkansas Division of Behavioral Health Services to support prescribers and managing patients with opioid use disorders across the state. So please give a warm welcome to Dr. Mancino.
So, Kim, for that introduction. I see some familiar faces in the audience. You've probably heard some of this before. Earlier this week, I got an email that said this was a suicide prevention and opioid use disorder conference, and I thought, oh no, I didn't prepare for the suicide part of that talk. And actually, I ran across something that was striking to me. Most of you are familiar with the problem of opioid, right? About 40% of opioid overdoses are thought to be suicide attempts. That's a significant number. All right, so Kim stole some of my thunder, which was, who am I? I was here for part of the last speaker. Who am I and why am I here, right? So I basically am a person who is a dripping faucet about increasing access to medications for opioid use disorder. And I've been doing this for well over a decade now. And I say I'm a dripping faucet because I won't shut up about this. I just keep talking and talking and talking. So today we're going to talk a little bit about what is medications for opioid use disorder and why is that important. So we're going to cover the problem and then what are some potential solutions. We're going to do some definitions so all of us are on the same page. And then how common is the problem? And then we're going to talk about treatment, specifically medications for opioid use disorder. So those are three of the terms that I'm going to use throughout the talk today. So let's talk about what those are. And you'll see that some of the old terminology is not on that slide, like abuse and dependence is no longer part of the language around substance use disorders. So what is misuse? So misuse can be incorrect use either by the patient or the prescriber. So the patient is, I've given them a prescription for hydrocodone 10 milligrams, one tablet 4 times a day, and they decide that it would be better if they took 2 tablets 6 times a day, right? So that's the patient misusing my prescription. The second big problem is physicians, and that's the 4 Ds. This is what leads to misuse that's contributed to by prescribers. Dated. So they missed out entirely on the CDC's recommendations for opioid prescribing, right? They're not keeping up to date on the fact that it's not a good idea to give someone 30 days of medications for maybe a hernia surgery that should only have 2 or 3 days of medications. Duped, right? Patients with substance use disorders are very savvy at convincing their physicians or prescribers that they need medication. And so as prescribers, we tend to want to help people, and so we're sort of at risk for being taken advantage of. Disabled. That's the prescriber that has a problem with substances potentially themselves or some other issue that causes them not to sort of do what's best for the patient, right? And dishonest is the most concerning one, and it's probably the most surprising, but there are physicians that have substance use disorders that may tell their patient, I'll write you a script for 300 hydrocodone, you just need to come back and bring me half of those back. Which is a little shocking, but sometimes occurs, fortunately not that commonly. Versus non-medical use. So non-medical use is illegal use, right? So on the left side is legal use. It was legitimately prescribed to the patient by the prescriber. On the right side is one of the most common things that happens in the state of Arkansas, which is, oh, I have back pain. My doctor gave me some medicine for my back pain. It's hydrocodone. Would you like some? Not recognizing that that's actually a felony to engage in that sort of behavior. Often taken for euphoria, to get high. Most commonly used medications in this manner are opioids, followed by stimulants and benzodiazepines. In the US, in people ages 12 and above, in the past month, about 2% of people had used or misused medication, and the lifetime percentage is almost 15%. So what is a use disorder? So this is the terminology that's taken over for the abuse and dependence, which is good because abuse and dependence were confusing even for medical students and physicians, right? And part of the reason for that is if I'm prescribed hydrocodone 10 milligrams 4 times a day, and I take hydrocodone 10 milligrams 4 times a day, and I function well, and I go to church, and I take care of my family, and I work, and I do all the things that I'm supposed to do, and I go on vacation and leave my hydrocodone at home, I'm going to go through withdrawal. Why is that? Because I'm a human being. Not because I have an addiction or a substance use disorder, but because I become physiologically dependent on opioids, which was why the term dependence was so confusing to people was, well, that person's dependent, right? They have a problem. No, they don't have a problem. So we shifted away from that. It's interesting, but when they were deciding this, these people that came up with the DSM-5 voted, and the vote was 5-4 to come up with this terminology versus using the term addiction, right? When we use the term addiction, a lot of us know exactly what that means, but they decided that this was less pejorative. So you can see there some of the criteria for use disorder, which are very similar to what we used to use for abuse and dependence. Do you know what thing they took off of the old criteria? Yes? The legal. Why was that? Why did they remove legal? Because that was easy, right? You got arrested for DUI, check, that's a problem, right? That made it real easy for physicians to kind of use that as a diagnostic criteria, but they took it away. The reason they took it away was because by the time you wandered into having legal problems, you typically had all these other problems already, and so it didn't add much useful information in terms of making the diagnosis. Do you know what they added instead of the legal? Craving. Craving is one of the most significant things that causes relapse in people. We're very good at getting people past the withdrawal symptoms, the detox. We can detox people all the time. And we can get them past that. Right? We can give them medications for all the symptoms of withdrawal, which we're going to go through here in a minute. But the problem is we don't do a good job of dealing with craving. And craving is what seems to drive relapse to opioid use. Okay, now that we're all on the same page, how common is this problem? 2021 National Survey on Drug Use and Health, they actually call people on the phone and ask them a bunch of questions and then record the data, so I'm not sure how representative it is of the entire population. They obviously don't get homeless people typically, incarcerated people typically, so they're missing significant portions of the population, but it's the best thing we have at this point. You see there about 1 in 5 people aged 12 to 17 have lifetime non-medical use. So non-medical use, using a medication that is not prescribed to you, is very common. Almost 40% of what I call emerging adults, ages 18 to 25, have past year non-medical use. So that's very common in young adults. And then over half of young adults 18 to 25 have lifetime non-medical use. So a significant portion of the people that are sort of trying to make their way in the world and figure out who they are and where they belong are using medications that have not been prescribed to them. Emergency department visits, the DAWN network, which is Drug Abuse Warning Network. It's interesting. I used to have a slide that was like 2011. This system actually went away for about a decade. They stopped recording this data, and then as the opioid epidemic kind of got into full swing, they said, we really need to pay attention to how many people are showing up in the EDs, because that's a significant drain on our resources, right? So almost 6 million drug-related ED visits, and 60% were related to drugs that are misused, so people taking meds that are not prescribed to them. And almost a quarter of those were opioids, right? So opioids, very common reason for people to show up in the ED. So on the left is hydrocodone, on the right is OCs. OCs are OxyContin. Because it says OC, you know that's the old formulation from Purdue Pharma. That was the one that used to be snorted, smoked, injected, because it was real easy to do that. And then they figured out that that was a significant problem, and so they asked Purdue Pharma to reformulate the medication, which they did, and now if it's OxyContin, it actually says OP. And they made it really hard to inject it, snort it, smoke it, but patients have figured out if you microwave it for 9 seconds and put it in I mean, you don't get 100%, but 40% is better than zero. So people are incredibly resourceful to figure out even all these things that are done. Has anyone heard of Opana or oxymorphone, right? Opana was a medication that was medium length acting, designed for cancer pain, to be taken orally. When they changed the formulation of OxyContin to make it more difficult, the prescriptions for Opana went up 400%. There is no reason for that to have occurred other than diversion, right? So the people that were addicted to the OxyContin said, oh, I can't do that anymore. I need Opana, doc, right? OC doesn't work for me anymore. Well, doctors contributed to the fact that there's no reason for them to have switched the formulation other than feeding into the addiction. Eventually, they caught up with Opana and they said, hey, you guys got to reformulate your drug too. Opana said, okay, fine, we'll reformulate it, but we're not going to spend a lot of time, effort, energy, money on that. So we just made a cheap version of it and said, here it is. Well, guess what? People continued to inject Opana, and then they ended up killing their kidneys because of the problematic reformulation. And so that's why Opana is no longer on the market. They really kind of messed themselves over by not taking the long view of this. And so OxyContin's the one that's dominating the market for intermediate acting opioids. So this slide just shows us that, used to be young adults, adolescents, used to use heroin if they had a problem, but in about early 2000s, prescription opioids became much more readily available and they overtook heroin, so it became much more common, especially in rural states like Arkansas, for kids to have much easier access to prescription opioids than they had access to heroin. In fact, a decade ago, if you wanted heroin, you'd have to go to Austin, Texas or Memphis, Tennessee to get decent heroin. The heroin that was in Arkansas was black tar heroin. It was not very good. So I'm sure you've heard of the triple wave of overdose deaths. There's actually now what's called a quadruple wave of overdose deaths, and we'll talk about that here in a second. But basically, the purple line is sort of the prescription opioids. As they became more readily available, people had an increase in the number of overdose deaths because of the larger and larger numbers of prescriptions and amounts of prescriptions and those sorts of things. And then the yellow line is heroin, which you can see lagged behind the prescription opioids, but kind of took off in about 2010 and resulted in significantly higher overdose deaths. And then right now we're still in the midst of the black line, which is appropriate because fentanyl is the leading cause of overdose deaths at this point in time. And you see there, it kind of took off in about 2013, and it is everywhere. I hardly ever had a patient come to my clinic that said they used heroin. Almost every single person that comes to my clinic now uses fentanyl. 9 out of 10 of them are using fentanyl, and they know they're using fentanyl. What's the fourth wave? Anybody have any idea what the fourth wave comes from? What is it? What? Xylazine? Close. It's actually methamphetamine. It's psychostimulants in combination typically with opioids. And part of the reason for that is people are diluting methamphetamine with fentanyl. So people are thinking, I need to get me some methamphetamine, and the people that are supplying the methamphetamine have customers who say, oh man, the methamphetamine, fentanyl together, that's where it's at, right? And they get lots of repeat customers. So they think, let's put a little tiny bit of fentanyl in everyone's methamphetamine, and then the person that's totally opiate naive gets a hold of the methamphetamine that they don't have any idea has fentanyl in it, and they overdose and they die. And we're hearing that story a lot. Back to that National Survey on Drug Use and Health, heroin use, over 1 million people used heroin at least once in the last year. A significant portion of those were really young people. And then prescription opioids far outstrip the heroin in terms of frequency of use, right there. Almost 10 million people. And about 500,000 of those are really young people, ages 12 to 17, which is why the opioid problem is continuing to grow. Striking number there, $1.5 trillion annual cost in 2020 dollars. That's a huge amount of money that the opioid crisis is costing this country. And that includes incarceration, hospitalization, medical care, you name it, overdose deaths and lost years of life, et cetera. So that's kind of this big number that takes into account everything that's being caused by the opioid epidemic. I want you to kind of pay attention to that bottom part of this slide. You can see there from 2006 to 2019, significant increase in the number of people going into treatment in the state of Arkansas for heroin, but pales in comparison to the number of people going into treatment for essentially prescription opioids. right? And where does fentanyl lie in this? We don't know yet. We don't have a good way to measure that at this point, right? Some of the people in the state are starting to go, oh my gosh, we really need to figure out how do we measure fentanyl use, because we don't do a good job of it. If you go to an emergency department, typically, do they test for fentanyl when they get a drug screen on you? No, right? They also don't typically test for methadone. They don't test for buprenorphine. They don't test for a lot of things, right? They just test for opioids, which is typically hydrocodone, morphine. You really need to test specifically for oxycodone if you want to pick up oxycodone. You often won't pick up oxycodone in your typical drug screen. Opioid use disorder treatment gaps, right? That's partly why we're here today. There isn't enough treatment available across the state of Arkansas, especially. A lot more treatment is available in other states than is available here. So you see there, pain relievers, over 5 million people with a pain reliever addiction, heroin 1 million. So about 6 million people have a disorder and need treatment. Less than half of them received any treatment of any kind, right? What is treatment? Treatment in 12-step meetings, right? Treatment is going to a residential treatment facility, a detox facility, an intensive outpatient treatment, that sort of thing. So less than half of people are getting treatment. Very important to understand that detox does not work. If you take away one thing from today's talk, it is that detox does not work. And why is that? Because of that craving problem, right? We can detox people and get them to the other side where they're past their withdrawal, but that obsessive thinking about, oh my gosh, I wish I had a pill. I wonder if so-and-so has a pill. Can I get some money to get some pills? I need to call so-and-so about some pills. And that's literally what's going on in their head while you're trying to do cognitive behavioral therapy with them, right? What? I'm sorry, what? Right? So access to treatment is restricted. So, you know, lots of famous people have died from the opioid epidemic, but most importantly, people we know and love have died from the opioid epidemic. It's affecting everyone, which is also why it has gotten the attention of the entire country. All right, so let's talk about solutions. So this is the great sort of debate here, right? I medicate first and ask questions later, right? That's the let's put Suboxone on the counter of the doctor's clinic and let people walk in and grab as much as they want and just walk out the door, right? There are people that espouse that approach. Versus, sorry, no water, we're just a support group, right? This is the other end of the spectrum. This is the medications are bad. You should never, ever, ever, ever use medications. You're replacing one drug for another. You're encouraging drug use, et cetera, et cetera, et cetera. And those two camps are why we can't figure out what to do in the United States, because they are so passionate about their position that everyone in the middle is confused. Well, which one's right? Who's right? Well, the right answer is in the middle, right? We need to use all the tools at our disposal, and that includes medications. What is the horrible, terrible thing that people want to avoid and why they relapse oftentimes when they've been sober for a day? It's this: a fate worse than death. Who's had the flu in here? Raise your hand. So a lot of you have had the flu. So think about the flu times about 1,000. That's how people with opioid use disorder view withdrawal. It's like having the flu times 1,000. If you have the flu, what do? What? Stay in bed. What else? Take meds. Yeah, they can, 5 days. It's now 3 days instead of 5 days with Tamiflu and all that stuff. Drink lots of fluid. fluids, but you kind of just get through it, right? Kind of baby yourself for a while. What if you had a magic pill that made it go away instantly? That's what they have. They know that if they have withdrawal and they use an opioid, their withdrawal will go away instantly. How would you be to take a magic pill if you had the flu and could make it go away instantly? And I'm talking about withdrawal being 1,000 times worse than the flu, right? So that's why we have such a problem with keeping people off opioids, is because they cannot stand that withdrawal phenomenon. So what are the symptoms? Runny nose, watery eyes, sweating, yawning a lot. Not too bad. Then it gets worse. Can't sleep, dilated pupils. They don't really care about that. No appetite. Goosebumps. That's where the term cold turkey came from. I'm going cold turkey. If you've ever seen a turkey with all of its feathers plucked, that's what they're referring to. And then irritability. And then it gets worse. All those symptoms increase, and then you start getting into the autonomic instability that we often see with things like alcohol withdrawal and benzodiazepine withdrawal. And then all of these problems too. And that one, the muscle spasm, is where the term kick the habit came from. Literally causes muscle spasms so their legs kick out, and that's why they came up with kick the habit. Bone pain, really interesting. Doc, it hurts all the way down deep into my bones. They'll actually describe it that way. It's this pain that's just really deep in their body. So what's the functional state of a person with an opioid problem? I don't care what it is, prescription opioids, heroin, fentanyl, doesn't matter, it's the same thing, right? You start out in the morning, you're sick because you haven't used while you've been sleeping, you wake up, you're in withdrawal, you use, and you go to getting high. And then you repeat this multiple times, often 6, 8 times during the day, to try and stay high. After you've been using for a while, you don't get to the high. You're just trying not to be sick. And patients will tell us that. I don't use anymore to get high. I just use so I don't get sick. I'm not getting high. I'm just trying to be normal and function. And functioning involves getting the money together to find more drugs and find drugs. Versus putting people on medication where they don't have to go through that cycle of just using to avoid being sick. And it's important to understand you don't see any time spent in this high area when you're using medications. That's the difference for the argument that you're substituting one drug for another. We're not. Why do we want to use medications? What are the goals? Prevent or reduce or eliminate withdrawal. Prevent use of their drug of choice. We want to keep them from relapsing to using opioids. We want to have them potentially lead a normal life where they can do all those things like take care of their family, have the trust of their family, avoid incarceration, have a job, pay taxes, et cetera, et cetera. So what are the medications? Naltrexone, methadone, and buprenorphine. So an antagonist, which is a blocker, which is naltrexone, goes to the mu-opioid receptor in the brain and occupies the receptor and blocks it, does not activate it, does not open it. It just prevents other opioids from getting to it. It's not reinforcing at all. And it includes naloxone, also known as Narcan, which is a very short-acting form of it, and then naltrexone, which is actually a derivative of Narcan. Versus a full agonist, which is also opioids of abuse, but in the treatment realm, it's methadone. Right? Methadone is a full agonist. versus my favorite drug, buprenorphine, right? Buprenorphine, also commonly known as Suboxone. Suboxone is kind of the Kleenex of the buprenorphine trade, right? Everything that's a tissue for blowing your nose is called a Kleenex, whether it's puffs or it doesn't matter, right? Everyone calls it a Kleenex because they were the first on the scene. So less reinforcing, less abusable, and obviously includes buprenorphine, and it activates the receptor at a lower level, which prevents people from getting high. So there's dose response curve, which includes efficacy. Efficacy involves pain relief, high, respiratory depression. So the full agonist can occupy and activate the receptor 100%. The buprenorphine or partial agonist occupies and activates the receptor somewhere between 40 and 60%, and then the antagonist does not activate the receptor at all. So let's talk a little bit more about naltrexone. So what's the idea behind naltrexone? Well, when we use it in animals, it is an absolutely wonderful drug. Why? Because we put the animals in a cage and then we teach them if they press a lever, they get a shot of heroin, and they press the lever like crazy. And then we give them naltrexone and they press the lever and they don't get high despite the fact they get the heroin because the naltrexone blocks it. And the animal is smart and says, well, I'm wasting my time pressing this lever. I'm just going to stop pressing the lever. So we extinguish the behavior. We can't really lock people up in cages. Jail doesn't count, right? And so naltrexone, although it should theoretically work wonderfully, you have to actually take the medicine or injection every time in order for it to have benefit. Craving decreases if opioids are not available, right? And that's a key. If I'm hanging out with a bunch of people that are using fentanyl in front of me and I've got naltrexone on board, I'm still going to crave opioids like crazy because they're triggering me like crazy. If the opioids aren't available, it does break that cycle of obsessional thinking about the next pill, the next shot, that sort of thing. But if they're in the environments that oftentimes our patients are in, they can't avoid thinking about opioids. Cue-induced craving, that means that if I show someone a picture of a syringe or a pile of heroin or something, having naltrexone on board helps them not be triggered as much by that cue, but it still doesn't eliminate it. And then naltrexone decreased priming, what does that mean? It means if I get a taste of heroin, that naltrexone will prevent me from wanting more heroin, but it still doesn't work perfectly. Naltrexone, FDA approved the oral form of it in 1984, the injectable long-acting in 2010. The nice thing about this is it goes into the brain, and if you have opioids in your brain, it kicks the opioids off the receptor, but that also results in precipitated withdrawal, which is why you have to wait a long time between when the person used their opioid of choice last and when you can give them naltrexone. It makes it a really tricky business. I tell people if the person with an opioid use disorder could not use opioids for 7 to 10 days, they wouldn't need my help in the first place, right? So you've got to do these sorts of things in places like a detox facility or like a residential treatment program or something like that where you can kind of control their access to drugs. Receptor affinity is 20 times greater than morphine, which is why it goes in and kicks the opioids off. Side effects listed there, not terrible. The nice thing is the liver toxicity seems to be eliminated with the injectable form of it. It seems to be restricted to the oral form of it. And we already know that the oral form doesn't work very well, again, because the patient has to take the medication every single day. And unless you involve a family member and they sort of to have this agreement that I'm going to make sure this person takes their naltrexone every day, and yes, I'm going to agree that this person's going to help me make sure I take my naltrexone every day, the person just stops taking the naltrexone, especially if it's oral. Well, guess what? If I give you an injection that lasts a month, you have to show up in a month to get your next injection, and if you don't show up in a month to get your next injection, it doesn't work either. So it's not the answer. The last thing there on the slide, opioid analgesics not effective. I don't know how many patients I have tell me, oh, doc, I can't get naltrexone. What if I get in a car accident and I need pain pills? Right? But that's the logic of a person with an opioid use disorder. I don't worry about getting in a car accident, and but they're so convinced that opioids are an integral part of their life that there's no possibility they consider living life without opioids. So we have to reassure them, oh, don't worry if you get in a car accident and you break your leg, there are medications we can give you in a controlled setting that override the naltrexone, and it's going to be okay. But it's amazing how many people flat out say, nope, not going to do it. Sorry, doc. So let's talk a little bit about methadone. So methadone probably has the most research around it and its impact on a variety of things, and we're going to cover some of those things today. Significant impact on the justice system involvement. So looking at people that were in methadone treatment, were they put back in jail? Only about 6 of them, or just over a third of them, ended up back in jail versus 100% of those that were not given methadone. And then did they use heroin? Every single person that was not given methadone used heroin versus only about a quarter of the people that were on methadone used heroin. This looks at, pink is observed, what's the annual death rate, versus the yellow, which is what we would expect, like what would a general population without an opioid use disorder look like. And so the key here is to look way over, the key here is to look way over here at this big one. Untreated, huge amount of mortality compared to what would be expected. Look at that one, involuntary drug court treatment. So you make someone do treatment that's in drug court that doesn't really want to be there. Doesn't work very well in terms of decreasing mortality. And part of the reason for that is because you make them stay sober and then they decide, I don't really want to be sober, and then they reset their tolerance and they use and they end up dead. Versus voluntary drug court treatment, right? A person says, I've got a problem and I need help, and fine, it's drug court, but I'm ready to change my life. Much lower incidence of overdose. Versus methadone maintenance, which has the best outcome, right? The idea is that if I give you and treat you with methadone for your craving, you don't have withdrawal, and I'm also giving you all the other services provided in methadone treatment, I significantly lower mortality associated with opioid use disorder. This looked at 6 different clinics, predominantly on the East Coast, big cities, looking at methadone treatment, crime days per year before. Pink is before treatment, and yellow, so huge decrease in the number of days that they're involved in criminal activity. Decrease in sexually transmitted infections or IV drug use infections, really, in people in treatment versus those that are not in treatment, cuts it by about half. And then, for us in the treatment sphere, abstinence, not using drugs, is a really important measure. If you're in treatment and then you drop out of treatment, you see that by the end of that first year, over 80% have relapsed to using drugs. So in treatment, about 20%, out of treatment, about 80%. So significant improvement in one of our easiest measures, which is drug use. So these are all the impacts of medications for opioid use disorder. These are the reasons why the federal government is willing to subsidize methadone treatment programs. For every dollar we spend on methadone treatment, society saves $7. That's a good investment. That's why they pay for treatment. Not because they care about the individual person with an opioid use disorder, okay? They pay for treatment because it's cost effective for society. Methadone kind of has a reputation. People can misuse it. People can take high doses and get high. But if you're being appropriately managed in a methadone treatment program, you are going to get a dose that is appropriate to you that will not result in getting high. It will just relieve craving and withdrawal. Those are some of the other side effects. No long-term problems with using methadone. Methadone's been around since the 50s. Okay, let's shift to my favorite. I admit that up front, right? Buprenorphine is able to be misused, right? One of the arguments against buprenorphine. Diversion and illicit use by injection, right? We thought, oh, the United States forced the drug company to create Suboxone, which is buprenorphine and naloxone, and that will prevent diversion. Because if you inject, smoke, snort the Suboxone, you will go into withdrawal, right? In Europe, Subutex, or buprenorphine monotherapy, was available for probably 20 years before it was available here in the United States. Low abuse potential versus other opioids. You see there, what's the average number of cases of abuse per drug abuse expert, right? So significantly lower abuse potential of buprenorphine and even tramadol versus oxycodone or methadone. So some characteristics of buprenorphine naloxone. You see there at the bottom of the slide, there's some new brands that are available. Zubsolv is a minty flavored tablet, and patients actually prefer the taste of that to regular Suboxone because it's not as bitter. Buccal film, Bunavail, kind of has disappeared in Arkansas. They just really couldn't convince people that there was significant benefit, and none of these are generic. They are just as expensive as the brand name drugs. And there are generics available that are buprenorphine naloxone tablets, buprenorphine naloxone films. Generics are available, so people prefer to prescribe those to these really expensive medications. Interesting, the buccal film is orange pastry, and they gave us a sample, which was a film that didn't have any medication at all in it. And so it tasted it and was like, it's not bad, kind of orange pastry. And then the patients would tell me, yeah, well, if they put the naloxone in it, it's a bitter orange pastry, and that's really nasty. So some people thought it was worse than the Suboxone was. So again, the idea, if you put it under your tongue, you primarily get the buprenorphine effect. If you dissolve it and inject it, you predominantly get the naloxone effect. What people have found is that if they inject the Suboxone, they will go into withdrawal for 20 to 40 minutes, and then the bup effect will overtake that and be there for a long time. And if you combine it with benzodiazepines, it's just like shooting heroin that lasts a long time. So patients have figured out, yeah, it has withdrawal, but I can manage that withdrawal if I know it's a short withdrawal. So unfortunately, the buprenorphine naloxone did not solve the problem of diversion. Does it work, and is it safe? This is a really powerful slide, right? Bup maintenance, withdrawal. So we put people on bup, which is the red, versus the green, which is no medication, and within 2 months, everyone had dropped out of treatment if you didn't give them medicine, versus a year later, 75% of people are still in treatment with buprenorphine. Again, we wish we would get these sorts of outcomes when we do clinical care. This is research, lots of hand-holding, lots of incentives, lots of other things going on. Our retention is unfortunately closer to about 50% than it is to the 70, 80% that we see here. But no question, no medication, they drop out. They go back to using drugs. Highly safe, you can use it both acutely, you can use it long-term. I have patients that I've been taking care of for 12, 13, 14 years on this medication, doing great, would never know they were on this medication, leading fully productive lives. Side effects you see there. No disruption in cognitive or psychomotor performance. Drive car fine, drive a truck fine, do most jobs fine. There's one subtle neurocognitive deficit that you wouldn't be able to detect unless you were doing that specific neurocognitive test, but it doesn't really affect people's ability to function. Overdose risk is very low unless you combine it with those CNS depressants listed there, right? So you can take as much Suboxone as you want, and in fact, if you take a bunch of Suboxone, you start to get the kappa antagonism, and then that actually causes withdrawal, makes them feel worse. So it's a disincentive to overtake the medicine. It's not like if you take a whole bunch, you're going to get high. You don't get high. You actually feel worse if you take too much medication. Those are some of the characteristics. Important unsupervised dosing. Walk into my clinic, get a week's worth of meds day one. Walk into a methadone clinic, you got to come 5 or 6 days a week every single day to get your medication. That's a very attractive alternative. So how well do these medications work? You see there, actually, it's interesting. Methadone maintenance is actually superior to buprenorphine in terms of outcomes. And we think it's because of the added structure and support and accountability and those sorts of things. It's not that much better, but it's better. Versus naltrexone, which is pretty bad, almost the same as detox, versus no medication, and 30% is really high. That's a really good outcome. That's probably lots of other things going on, like lots of support and chem-free living and contingency management and all sorts of things. This is a drug, LAM, probably none of you have heard of. It was essentially a long-acting methadone type medication that I could dose people Monday, Wednesday, Friday, and it would last, which meant if you lived a couple hours away from the clinic, it made it more convenient for me to give you this medication. It had some cardiac problems, and then it didn't sell very well, and so the company took it off the market, and so it's no longer available to us. But it was a really wonderful medication. So we've talked about the problem, some potential solutions, treatment. Again, opiate agonist therapy, which is another term that's been used for medications for opioid use disorder, but specifically looks at the methadone and the buprenorphine side of things, right? The naltrexone is not an agonist, it's an antagonist, but it doesn't work for everyone. I've had people tell me, man, I was in Suboxone and it didn't work for me. I still use drugs, and so what worked for me was no medications. Well, awesome, that works for you and that's great, right? But this has the potential to help a lot of people. A lot of people don't do well without medications and they end up dead. Last thing I'll say is, I'm here, I'm a prescriber. I talked a lot about medications for opioid use disorder today, right? I am a firm believer in the idea that a pill is not enough. I feel that treatment is critical to a person getting into recovery. My patients think that the medication is this much of their treatment, and the therapy is this much of their treatment. And I think therapy is this much of their treatment, and the medications are this much of their treatment. I don't subscribe to the leave the Suboxone on the front counter and let them take as much as they want, but I also don't subscribe to the nobody ever should have access to medications. I'm right in the middle. And that's the message I want to leave you with today, is I don't believe medications for opioid use disorder are a magic bullet. They are one tool in our armamentarium for trying to get people on the path to recovery. Recovery is a significant undertaking, and it involves more than just taking a pill every day. All right, so we have lots of time for questions. Questions that folks have? Yes.
Can you comment on the
No.
morphine or other meds in the ER? People are showing up in the ER and there's been a lot of
Yes, so thank you. There's a couple things I should really cover today. So there's been numerous studies recently that basically say the emergency department is a wonderful place for people to start medications for opioid use disorder, specifically buprenorphine. And there's something that goes along with that. Legislation was recently passed eliminating the need for a waiver. Used to be that if you wanted to prescribe buprenorphine for opioid use disorder, you had to take 8 hours of training to get the waiver from the DEA, or if you were an APRN or a PA, you had to take 24 hours of training, right? They got rid of that. Prior to that, if you got a waiver, you were allowed to take care of 30 patients. And then after a year, you could request to take care of 100. And then fairly recently, 2021, they changed that to allow certain physicians to take care of 275. You had to have a comprehensive clinic, meaning you had to have counseling and drug screens and all that in your clinic, or you had to be an addiction medicine doctor, either psychiatrist or addiction medicine certified. It's interesting, I read a study the other day that looked at that issue over about the last 5 years, from 2017 to 2021. The majority of prescriptions were generated by the prescribers who had 275 patient allowance. The elimination of the waiver, in my opinion, will not dramatically increase the number of doctors that are going to prescribe buprenorphine. It's not going to have very much effect at all, unfortunately. The doctors that can prescribe for 30 patients or less tend not to prescribe buprenorphine at all. So the idea that the barrier to prescribing buprenorphine was the waiver training, not true. The barrier to prescribing buprenorphine is the philosophical opposition and the lack of comfort of taking care of patients with mental health issues and substance use disorders. That's our problem. And that's why the organization like this is so important for us to get those two to be working in tandem and realizing that we need to take care of patients soup to nuts, right? Oh, you have a psychiatric problem, you need to go over there. Well, maybe you do, but maybe you don't. Maybe initial treatment and that sort of thing can be taken care of by the PCP, but we're not there yet. We're nowhere close to that yet. So the idea is, now that waivers have been eliminated, that means the doctor in the emergency department can prescribe buprenorphine and then potentially hook the patient up with follow-up, right? Find the clinic that's down the road or down the street and say, if you go there tomorrow or the next day, I'm going to write you a script for 2 days, 3 days. Maybe it's a Friday night. I'm going to give you medicine today in the ED. I'm going to give you medicine for Saturday and medicine for Sunday, and then Monday morning I want you to show up at this clinic that will take over your buprenorphine treatment. And when they do research on that, they found that that model works significantly for increasing patients accessing care and staying in care up to 3 months later. So a really important thing to convince people of, but we are really behind the curve in terms of convincing ED docs to do that. We have a project at UAMS in collaboration with an ED doc that's out in the community that goes and works at a lot of the little EDs across the state. And she's real passionate about this, and she wants to educate people about this and Narcan and what's the next step, and if I give them Narcan, can I send them home in an hour? No, you can't. They might die because they might get narcotized because the fentanyl lasts longer than the Narcan. But doctors don't know that, and so we need to educate them. You got a question?
Is the goal for them to stay on this for the rest of their lives, or is there a period of time that they're on it?
The goal is for them to do whatever works for them. And if that's the rest of their life, that's what works for them. We don't ask that question when patients have diabetes, right? We don't say, are you going to have to take insulin your whole life? We know the answer is yes. Well, for these folks, a lot of times they're going to have to take medications for the rest of their life. And in their it works for them. Now, I have patients who say, I don't want to be on this medicine forever. Great, then let's get you stable. Let's talk about what your life looks like when it's time to get off of this medication. We aren't real good at getting people off successfully, I'll just let you know, right? Why is that? Because at the end, you got to go through withdrawal, right? So, and then it depends. What's their recovery program look like? If the patient has done the medicine is this important and therapy is this important approach, they don't have a recovery program. And the first time they're hit with a stressor, what do? Oh, I use pain pills, I use opioids, right? As opposed to I call my sponsor, or I go for a run, or I take a hot shower, or I journal, or I scrapbook, or I whatever. Right? I don't have a recovery program in place, so I don't have anything to deal with the stress, and I'm relying solely on the medication. So if somebody tells me I want to get off the medication, I say, well, let's build up your recovery program so that that can be a realistic goal for you. Other question, Helen?
You had a graph up that shows death rates. I don't know if I'm reading this wrong, but essentially what I read was not untreated versus involuntary treatment in drug court essentially has the same effect.
Yes.
Is that correct?
Yes.
Okay. Is there anything in your opinion we can do to improve our special supported drug court programs to have a better impact on those treatment protocols that we have?
You know what I would say, and this is not what drug courts do, but motivational interviewing, right? What do you want to get out of this? And unfortunately, you know, we talked about the lack of access to care and the fact that only half of people got treatment. Some people don't want treatment. They don't care that they're in jail. They don't care that they have legal involvement. Their addiction is so powerful that that's just the price of doing business, right? Okay, got to go do 6 months in jail? No worries, right? I can use meth in jail. I can get opioids in jail. I can get Suboxone in jail. It's not a big deal, right? So that's you know, we cannot force people to do something they don't want to do. And that's not something we talk about a lot, right? The idea that I can't help every single person, even that walks into my clinic, right? You'd think, if they're going to see Mancino, they must want some help. Not necessarily. There's a lot of reasons they're there, and a lot of times it isn't because they want help. It's because they're in drug court, or they're about to go to court, or they're going to lose custody of their child, or their spouse is nagging them, or their children are, a million reasons they show up, not one of which has anything to do with I'm ready to stop using drugs. I just really want these other problems to go away. Can you help me make these other problems go away? My spouse will stop hassling me if I'm in treatment. I'm not sober, but she doesn't need to know that. He doesn't need to know that, right? Will you sign a release so we can communicate with your spouse? Absolutely not. Okay. Yeah, forcing people into treatment, which is why Act 10s are not very effective, right? You familiar with Act 10? Act 10 is the mental health court for substance use disorder. So a family member can go to the mental health court and say, my significant other, spouse, whatever, has a huge drug problem and they're about to die and they're killing themselves and they're doing this, that, and the other. And the court will say, okay, you're remanded to treatment for 21 days. Well, number one, the person can walk into treatment and say, yeah, this is a big mistake. I don't have any idea why I'm here. My spouse, significant other made a big deal out of nothing. I don't have a problem. Yeah, how much do I drink? Oh, a beer a day. Drugs? Oh, I smoke a little weed. I don't know what the big deal is. And the treatment facility will let them leave, right? Let's say you somehow convince the person to stay if they don't really want to be there. Then just spend 3 weeks having a vacation and then get out and keep doing what they've been doing before they got there. Which is why the motivational interviewing approach, where you try to meet them where they're at and you try to move them slowly from pre-contemplation, I ain't got no problem, it's your problem, to, well, maybe I have a problem. So I got a problem and I need some help. And I'm willing to do anything to get the help that I need. That's what we're not very good at. And you think about it. I lost my job, my spouse left me, my children left me, I have no money, I have no place to live. You'd think those would be powerful motivators to get someone to change their life. And in spite of all those things, we know of people that continue in their active addiction because it's more important to them than the loss of all of those things. It can be very heart-wrenching to see someone kind of in that destructive path. But it can then become very powerful when that person who you think is never going to get it, gets it and turns their life around, and it can be so amazing. But it can be so difficult to work with folks that just aren't ready. I have a saying that I use with a lot of the people that I work with at our clinic. I say, you know, sometimes we're only responsible for planting the seed. All right? And it's amazing how many times the person leaves treatment and goes and does their again, and then comes back and leaves treatment, and then one time they come back and they're ready. And they come back because we planted the seed, and they knew we care, right? That's why we're here. That's our purpose. We want to, and that's a difficult challenge for all of us, no matter what you deal with. Mental health issues, substance use disorder, poorly controlled diabetes. I don't care what it is, it's really challenging to take care of patients who aren't really ready to make the changes that are necessary. A magic wand. I think the future for me would be access to care for people that want it without significant barriers, right? And barriers for me involve the social determinants of health, right? Transportation problems, stigma going away. I think if I had a magic wand and I could only have one thing, it would be to make stigma go away, right? I think that's one of the most significant barriers we have to both mental health treatment as well as substance use disorder treatment. And mental health is actually, people are okay with anxiety and depression as more and more public people come out. Patients with substance use disorder don't like to put themselves out there as the face of an illness as much as people with depression, anxiety, et cetera, are willing to do that. So if I had a magic wand and only could change one thing, it would be to eliminate stigma. That would be one heck of a wand. Yes, sir.
I'm a family physician in Southwest Arkansas, and so I tested in UAMS where I did med school. We didn't get any classes on this, so as a physician, you're pretty uncomfortable with that. And I've been working with Dr. Gibson and Avian, but what can you speak on? Has that changed? Are the students getting any extra training on this? Too, also just the reimbursement. I'm a busy family physician and trying to get the resources to help me have a program. Not everybody's knocking on their door to move to D Queen for whatever reason. And just social terms of health. I mean, we get asked if we're asking those questions, but we don't have answers for when they give an answer. We don't have resources. So that's been my dilemma. I'm trying to get something going. I want to. But if you could speak, that's a several-part question.
Yeah. Before the pandemic, I actually made a tour of the state, went to places I had never been before, and I think DeQueen may have been one of the places I ended up at. I actually have a collaborative agreement with a nurse practitioner in Horatio. I know. And part of that is probably, like you said, the busy clinician. I got a million other people with a million other problems. And again, this population, like I said, is not easy to deal with. I think having reasonable expectations for what you're able to do. So you may say, you know what, I'm going to take care of the 2 in 10 patients that come in, do awesome, take their medicine, turn their life around, and I'm going to help those 2 people. I'm going to leave it to Mancino to take care of those people that struggle and have co-occurring psychiatric illness and multiple drug use, and they just in and out and in and out. That's not the person maybe that you're designed to help. So I think having reasonable expectations for what you're able to do. And to create a model that works for you, right? Your model may not be as exotic as my model, right? You may not have a counselor embedded in your clinic. You may refer that out, right? You may take care of depression and anxiety that's pretty straightforward, but that person that I don't know if they have bipolar disorder or not, I need to get someone else to help me with. So, necessarily to psychiatrists in DeQueen, Arkansas. But I think thinking about the idea that there is going to be a portion of people that walk into your office that could benefit, and if you look and you find you can offer, and some of them will take you up on it, and then you will have some amazing outcomes. But I think having realistic expectations, right? And the nice thing is, there is reimbursement now for like screening, brief intervention, and referral to treatment. A lot of insurance providers are allowing more visits if you're managing a person with opioid use disorder with medications. So there are some changes being made. Prior authorizations have been eliminated. That was one of the me dripping on people's foreheads that resulted in change. So I would just say, and then we are a resource. There's a program called Matriarch where you have access to Project Echo on Fridays, and you can bring cases and you can get consults. You can have a psych patient. You fill out a form. We'll set up a telemedicine visit. They're still your patient, but we can make some recommendations. Hey, you may want to try this medication and see him back, and that sort of thing. So there are far more resources available to you if you are in a remote area of the state that don't have the access to a lot of the things that I have access to here in Central Arkansas. Does that answer your question? Good. Yes, I think we're close to out of time. 4 minutes, something like that.
Showed two graphs of three graphs of two different waves, and it seemed like in 2010 there was a direct increase with heroin, and in 2018 I think it was 2014 for fentanyl. Is there any reason, context-wise, those 2 years?
You know, I think it's just a matter of, like, I don't think something happened in 2008 or 10 and 2013. I just think that was the inflection point. Fentanyl is the thing that became terribly inexpensive. You can transport it easily. I mean, you can transport enough fentanyl to kill 100,000 people in a box this big, right? And you can bury it in coffee and things and keep the drug sniffing dogs from being able to detect it and all those sorts of things. And I think it just became a matter of supply and demand. There were people in the midst of their addiction who got cut off from the prescription opioids because we became a little wiser about overprescribing and all those sorts of things. And they still had their addiction and they lost their access to these medications. And so they looked for alternatives. And heroin was the first one, and then fentanyl was the second because it's even cheaper than heroin, right? All right. Well, thank you so much for your attention today.